Hello and welcome to Chief Among Friends. I'm your host, Dr. Chris Hobson, Chief Medical Officer at Orion Health. On this podcast, I chat about topics ranging from technology priorities, new innovations, and integrated coordinated care, and sustainability. You can follow the conversation on hashtag Chief Among Friends, and be sure to follow me on Twitter at Dr. Chris Hobson. In 2021, the eHealth Initiative listed their two objectives for health IT in the US for 2021 as number one, COVID-19, and number two, addressing systemic inequity and discrimination. Nothing else matters. Today, we're going to take a look at machine learning with those issues top of mind. I'm very excited to have my friend Dr. Kevin Ross with me to discuss machine learning from the perspective of his extensive work in this space. Kevin Ross is Director of Research at Orion Health and Chief Executive Officer for the Precision Driven Health. Precision Driven Health is an award-winning research partnership applying data science to enable precision health. The organization establishes collaborations between clinicians, data scientists, and technology companies, applying the latest advances in data analytics to generate health benefits through software tools. Kevin is founder and chair of the New Zealand Data Science and Analytics Forum, a community of over 2,500 professionals, and a board member of Health Informatics New Zealand. He was previously chief scientist of optimization modeling at Fonterra, associate professor of technology and information management at University of California, Santa Cruz, and a principal consultant for PA Consulting Group. He has also worked for NASA, Bell Labs, Eli Lilly, and London Councils. Kevin holds a PhD from Stanford University and a BSc Honours from the University of Canterbury. So very excited to have you with us today, Kevin.
Thank you, Chris. It's nice to be on here.
Yeah. So first question, why should we apply machine learning to population health?
So population health is a really broad term, but fundamentally in the middle of population health is a lot of data. And there's more and more data that we're getting access to because people are collecting and sharing data from different mobile applications, different wearables, social media, as well as traditional health records. And there's no way that we can expect our health professionals to actually understand and process all that data themselves. Now, people are really good at some things and machines are really good at other things. And machine learning is really an advanced technology that can help with pattern recognition, which will help us with actually processing all that data. So if we want to understand the health of a population or the health of an individual, we're going to have to process a lot of data, match that against other similar records that are out there, and use that information to make better decisions or inferences. And machines are really good at a part of that process, in particular the part that involves lots and lots of data processing. And that's what machine learning is really all about. It gives us the possibility that we can define a problem, put input and output data examples to the machine, and then using that, machine learning basically can take a lot of things that would take people a long time and actually do that in a more sort of automated way. So the fantastic opportunity we have is more and more health systems are collecting more data and pulling that data together through areas like a health information exchange so that data about one patient and a population of similar people can go through the same system. Machine learning has a really powerful role to play in making that all work better to give us better health outcomes in the end.
I was going to do a side discussion. So I'm really interested in the concept that as humans, we can only hold about 7 elements in our brains at the same time. And so when I listen to you talking about machine learning and population health, it sounds as though the machine can hold a lot more than just 7 things at one time. So it must be part of the advantage here. So let's look at the experience that you've had with the Precision Driven Health Partnership and the work that you've been doing in New Zealand. And in particular, as well as kind of machine learning and population health, let's take a look at the potential for bias. Obviously, that's a concern, and that links back to inequity in all things healthcare and further. In your work in New Zealand, as an actual example, what's the nature of ethical problems that you have addressed in New Zealand? What was foreseen that could go wrong, and how did you deal with it?
So for background, New Zealand has a diverse population. So we have a majority of people who have European descent, but substantial minority, important minority groups, including Māori, who are our indigenous population, other Pacific Islanders, and Asian, and they all make a fairly substantial minority group. What we know is that health outcomes have been historically poorer for those groups. They tend to be at the lower end of socioeconomic factors on average, and just like in the rest of the world, and in the United States as an example, those groups experience poorer outcomes with their health. Now, one of the things that we're really conscious of in New Zealand is that lots of great research happens in the rest of the world, and we want to take the best of that and apply that to New Zealand and maximise the benefits to those who can gain the most. The dynamic we've got to be aware of is that most research around the world happens on European populations. So whether it's United States or Europe, the overwhelming majority of any sort of medical research traditionally has been applied to populations that are majority European. And that means when you take anything, whether it's a drug or a device or a machine learning algorithm, you have the danger that because it was designed to work really well and has been tested and approved to work really well in another context, bringing it into this new context, you can't guarantee that those same gains will be experienced by a different population. And so it's just like the question of, will this drug work on this population? Machine learning is built on data sets, and data sets are built based on what you're able to collect and where you're able to do the research. And so one of the key things that we do a lot is try to transfer models that have been developed in other countries and see how they might apply in the New Zealand context. And so you want to make sure, for example, that if you're changing the way that you're delivering care by using data science, that you're changing it in a way that benefits those who need it the most. There's a real potential in any of these types of applications that everyone benefits a little bit, but the people who benefit the most are those who are already somewhat better off. And that's what leads to what we think of as that widening equity gap. So the rich get richer, if you like, in a health context. So those who have always had pretty good outcomes tend to benefit a bit more from a lot of these sorts of initiatives. And that comes down to all sorts of things. Just simply the fact that your underlying data set that you build a model on means you do all this great work in data science to tune it to be as accurate as possible, but it's accurate as possible for those who are represented in your data. And if the New Zealand population is not represented in the data, then it's possible that the models won't be as appropriate. So I guess one of our really big ethical questions we ask there is, well, what do you do with that information? You've got this, whether it's a device or a model that's been proven to be valuable in a health context, but not within your population. At what stage do you decide that it's a good thing to release that for use in the New Zealand population, New Zealand context? So what we've been doing a lot of in that area is putting together collaborations where you link the data scientists with the clinicians, with some of those consumers and those particular ethnic groups to really understand what are the implications of using this model in this context, with an idea. The idea is you don't want to get in the way of good things that have been proven that can benefit some people, but you do want to make sure that over time you are making that equity gap smaller over time. So you've got to sort of almost set up the incentives in such a way that it's important and almost required to actually do the validation study in the right way to actually make sure you're releasing models that are going to benefit those who traditionally have missed out a bit. And that's just the way that things have evolved and research has evolved. Is these equity gaps have gradually gotten larger over time. Now everyone lives longer now than they did 50 years ago, and so everyone has had some benefit from technology. But the reality is that those benefits have disproportionately been to those who, at the start of that 50 years, were also pretty well off, relative to those at the bottom end of the scale. So we really think carefully about that when we put together a research collaboration and get into the areas of building models. And we've had some experience, particularly through COVID, of this sort of thing, where we've really had to think carefully about the way you might use data science and algorithms in a New Zealand context.
So you've taken algorithms or models from internationally developed, and then you've applied them in New Zealand. And then could you talk about you go about that process? You have committees or best practices, or how do you actually what you do when it gets down to the nitty gritty?
Yeah, so one example of this that we've been involved in the last year is, so we were a part of New Zealand's COVID-19 response and trying to bring models into the decision-making process, which on the whole has been a pretty positive experience in New Zealand. We've deployed this technology called the New Zealand Algorithm Hub, which is a freely available library, if you like, of algorithms to be used by the New Zealand health sector. And so in doing so, we had to ask the question, well, which models were appropriate for use in New Zealand? And in particular, that's quite an interesting question, because New Zealand hasn't had many COVID-19 cases. So most models that have been built around the world related to COVID, whether it's, what's the likelihood that someone who gets COVID will end up in hospital, or likelihood of mortality, and these sorts of things, haven't been tested on the New Zealand population. And frankly, we don't want to test it on the New Zealand population. We'd quite like to keep it that way. But what we were doing is, setting up a hub with these algorithms so that if there's an outbreak, we have the tools available to deal with it. And so we put together a governance committee for that. And probably the key thing of that was making sure that was quite wide and representative. So we have people on that committee who specialize in ethics, people who specialize in data science, clinicians, consumers, people from Māori interest groups. So a really wide range of different perspectives. And what we've done in that context is put together, you can think of it as sort of a standard model questionnaire, where for any model that we're considering releasing sort of on a standard piece of technology, we ask a lot of critical questions. So how has this model been developed? How has it been tested? What do we know about the outcomes for places that have used it? What are the intended uses of this algorithm, and what do we think the potential unintended uses could be? And so we go through a fairly rigorous process where we'd actually have someone almost set up like a little bit of a dragon's den or court case type of scenario, where someone comes along and says, I want to put this algorithm on the hub, and they fill out this questionnaire and then essentially stand before this committee and ask and answer these questions. That can be quite challenging. The idea of the process is seldom to actually say no, but more often to say, here are the guidelines that need to be included before we're willing to release this. Because again, you've got to get the balance right here. So we can't possibly have an algorithm that's been tested on the New Zealand population without releasing COVID-19 into the population. That doesn't mean there's not value in having those algorithms available in case there's an outbreak. And so we're quite deliberate in saying our goal isn't to be perfect here, but it's to make sure that what we do leads to really good transparency, so that everyone understands the background and the reason and the logic for using this. And that to the extent possible, we've put processes in place to make sure that once people start using these, they'll be monitoring this, they'll be reporting unintended findings or unexpected findings. And so we've had a robust but collaborative governance process is probably the key in there, that the people involved genuinely want to see the benefits while minimizing the chance of harm. And often sometimes you get into the mode of people are only interested in zero chance of harm. And if you get down that track, then you end up not doing anything. And so I think getting that balance right is really key here.
That's really interesting, actually. I hadn't thought of it as a court case, dragon den scenario, but it sounds like it works really well. And I certainly think that whenever, as you say, you bring in a complex technology, it makes a lot of sense that you look at it from a lot of different perspectives before you move ahead. So I'd like to just see if we can take the conversation. So you've done these things in New Zealand and they've certainly worked well. So if we're looking in terms of North America or Europe or outside of New Zealand, do you think the same kind of approaches would work well? What do you think? Do you think that the Dragon's Den approach has got adequate protections for removing bias against vulnerable populations, for instance?
Yeah, so it's a great question, and I think obviously the context will differ in each place, but the fundamentals are always going to be the same, no matter who you're providing care to or policies for. You will be wanting to take best practice from elsewhere and apply it in your context, and it will never have been perfectly designed for your own population unless you've done the study yourselves. And obviously, we have experience of doing the studies ourselves as well as taking models from elsewhere, and as does anyone else in the United States in that kind of context. Mm-hmm. All of the evidence that I've seen suggests that as long as you're really robust and transparent about the way these things work, we can all have that same kind of mentality of how do you take the best from what's being produced elsewhere. How do you think through the potential for harms and the potential for biases, and then implement things with really good controls and guidelines around them? So the first thing in all of it is just to recognize the potential for these, both recognizing the value, so the reason you're trying to do them, as well as recognizing the risks. One of the things you've got to be really aware of is everywhere in the world, some people have had poorer outcomes than others. And That's just a fact, and we're all aware of it. One of the things I think the United States does better than most places is think about the incentives that are involved and try to set up incentive schemes that actually lead to the right outcomes. And sometimes that gets really complex. But in general, one of the things that I advise organizations and governments to do is to really think carefully, how do you incentivize better health gains for those who currently have poor health over small health gains for the majority? Because that's what we really believe as a society. We actually want people who have poor outcomes to improve more than those who currently have better outcomes. The only way you can really get there is by incentivizing everyone involved to play their role in making that happen. And so, down to relatively simple modeling, things like the objective that you put against a model is weighted towards benefits to some groups over others. I think it's really important that we get explicit about some of those things, that actually it is better to increase someone's life expectancy from 64 to 65 than from 84 to 85. And in being explicit about those sorts of things, we can then say, well, in order to do that, that means I'm not trying to necessarily increase the average by as much as I can. I'm actually skewed towards trying to help certain groups. Data science and machine learning is able to handle all these sorts of things, but you've got to be explicit in the process about how you actually want to incentivize them. I think that the other thing just to be really aware of is that often, our goal with health systems and things is often when we bring in technology to make them more efficient. And if historically there's been inequities, then there's always a danger that you can just more efficiently increase those inequities. Because by definition, if you just do everything you're currently doing faster and quicker and cheaper, you'll essentially push things through faster, and those gaps tend to get wider. So, if everyone gains the same percentage, for example, the actual absolute gap between the top and the bottom gets bigger. And so we have to really think about, what's our objective? Is it more efficiency, or is it more gains skewed towards those who need them the most? I think, in thinking about things that way, you then start to recognize, well, what is the data that drives these models? Where does it come from? Why is it biased? So often, data that drives machine learning is often biased simply because it captures those who have had high quality data captured about them in the past. So again, those who have had advantages tend to have more devices, more internet access. They might have had more stable kind of healthcare over their lifetime, and therefore their digital record is a better representation than, say, a minority group that might have had changes in healthcare, changes in insurance on a frequent basis, perhaps homelessness periods where they've not been captured, and there might have been situations where people didn't trust the system and therefore weren't entirely honest about their medical records. There's lots of reasons why we might not have high quality data about a subset of the population, and those reasons tend to bias themselves towards those who actually have poorer outcomes. So we tend to have poor quality information about a subset that have the most to gain. And therefore, we have to think really carefully about how we sort of counter that in the way that we design the models, as well as the way we actually design the healthcare delivery and the system around it.
I think that's very interesting. At Orion, we've always had a long-running interest in care coordination. And a variation on the problem that you're describing is, who do we invest resources in for care coordination? So it's very similar to who gets incentivized. And the problem's been expressed as, if we invest care coordination resources across the whole population, then we're clearly spending more than we need to, because we're spending it on some people who don't need care coordination. They can manage their own care. They can do well by themselves. So it becomes then, who do we target, and recognizing those people who should be targeted for interventions. And it's something I've puzzled on. So it would be very exciting if the machine learning can, say, guide the targeted interventions to this group of people as opposed to that group of people. And of course, if you can do that without, as you said, automating the injustice already. Another kind of interest that we have, obviously, as a health information exchange and population health vendor, we've had a lot of interest in safety and privacy issues. So really two questions rolled into one, but if I'm a patient and my data's in the health information exchange, should I be worried about potential privacy when my data is being used for machine learning? Obviously, we've heard things, Google Cloud sucking up all of the data. So as a patient in an HIE, say perhaps in a statewide HIE in New Mexico or somewhere, should I be worried about the privacy of my data? And similarly, as a patient, and these recommendations are going to be made from the HIE, should I be concerned about the accuracy and safety of the recommendations that may come through?
So what we're finding is people are more informed about the possibilities of misuse of data or sort of privacy breaches and all of these sorts of things. And absolutely, as individual citizens, we need to be concerned with our privacy. It tends to be true that in health, people are quite conservative about how much data sharing happens, and tend to be almost less willing to share data than they are in other sectors. And also, often you find actually that we share data less in health than consumers and patients would expect us to. And so one of the sort of interesting dynamics is people see their data being used by large social media or other sorts of organizations, and they kind of assume that the same sort of thing does happen in health. In reality, it doesn't, in that anywhere near that scale. You don't have the equivalent of a Facebook type of scenario where the health system knows lots about lots of individuals and is sharing that and particularly marketing that and using that for marketing. In general, I think HIEs are the sort of organizations that are trusted entities within the system. They're absolutely set up with privacy, and you need to have good technology like the sort of thing that Orion provides to make sure that people's privacy is protected. And, historically there have been breaches, but they've not been all that frequent, the number of sort of breaches of people's health information. There is always the sort of worry of what various actors could do with more health information, but in general, those involved in the research side of things are highly cognizant of those issues and tend to, for example, strip out personal information before they share it with researchers or machines or these sorts of things. And so I think we're developing some pretty good protocols and procedures around protection of privacy. I think again, if you think of it from the potential gain as against the risk, you've got to think in those terms. It's not like there's zero risk, but there is also a huge amount of potential benefits to society as a whole if we do this and do this well. But again, we've got to make sure we're doing it in the context of having human oversight, people who are, like the governance group I described earlier, involved in thinking through, well, what could go wrong here, but also who have the attitude of actually there's something we are trying to achieve here, and it's better outcomes for the whole population. How can we make sure that we maximise the chance of those benefits while minimising the chance of the privacy breaches or any other sort of potential harms that could come about?
Absolutely. So I think that's reassuring to people, and it's reassuring, I guess, to know that this is being overseen by, highly valid committees that are taking a broad picture and considering this from multiple different angles. I think that's really excellent. And so New Zealand's done well in that space. And obviously, as you said before, New Zealand's done a world-class job in managing COVID-19. I am interested, though, if you look outside of New Zealand or New Zealand and Australia, where there have been so few cases, and we look at North America, COVID's obviously impacted people of colour, essential workers, marginalised workers, and so on. And as you said, it's a textbook where it's hard to get the data from those people. So given all of that, would you like to maybe just pass some more general comments about machine learning, where it could play a role in management of COVID-19? I'm thinking here, so the kind of really current issues are really twofold. One is, are we hitting a third wave? Are we going to get overwhelmed with more cases given, on the one hand, vaccination, and on the other hand, new varieties of COVID that are more transmissible? So does machine learning, can it help us predict where that's going? And can we use anything from machine learning to help us maybe identify people who might do poorly when and if they capture COVID-19?
Absolutely. I mean, the reality is COVID-19 has been one of those sort of watershed moments in terms of data within the health system, where you've actually seen huge amounts of data sharing and knowledge sharing across the globe, where we have readily seen sort of sharing of at least case numbers by different geographic breakdowns, and some of that broken down into different ethnicities and these sorts of things. So you're seeing so much more willingness to share, largely because everyone recognises that actually we're all in this together at the same time, and sort of one wave is gonna follow another one, and if you can learn from someone, even just a couple of weeks ahead, then it makes all the difference in the world. I mean, New Zealand's COVID response was successful largely because we didn't have our first real outbreak until a few weeks after other parts of the world, and so we could look at the data that had been shared from those places and say, well, if we don't get on top of it quickly, we can see exactly what's going to happen. And so same thing applies here, is whether you're in the United States or Canada or Europe or the UK, we can all be monitoring what's happening everywhere in the world and seeing that there are certain things that lead to outbreaks, certain dynamics. None of our models are perfect, but if you compare this with any sort of epidemics of the past, we've got so much more information coming almost literally in real time, that you can have an army of data scientists really looking for unusual behavior and sort of outbreak type of scenarios, and you can use that information to inform whether it's policy settings or, in the COVID setting, a lot of the questions today are around, so how do we best get this vaccination program out to those who need it the most as efficiently as possible? And in that, we've got this trade-off between being highly targeted but a bit slower versus really fast and just getting it to everyone. And I think if you put that equity lens on it, then there might be arguments to make around being deliberately targeting for particular groups that we know are more likely to experience worse outcomes, or who might honestly have already experienced within their population a higher proportion of the poor outcomes to date. And so you might look at it from, well, who can we support who's actually been disadvantaged over the last year? Again, in all this, you've got to be cognizant. Nobody's trying to disadvantage any other group. And part of the rhetoric that gets really frustrating in all this is when it becomes an us versus them type of mentality. And, I've never come across a health professional or organization that wants a particular group to have an advantage over another one. So you've got to kind of put the whole context into the picture that, we share a lot of data in health in order for everyone to benefit. The general will of the people that are involved is really values driven, and really trying to help as much as possible for those who, for lots of different reasons, have had poor outcomes in the past. I think the fact that you've got good models around the world and people are willing to share them and put them on, things like a library of algorithms in different parts of the world that have been useful in those contexts is really helpful. We've benefited hugely from others who have aggregated research that they've seen across different places and put them on a dashboard that you can see, and then you can quickly get information really quickly out to those who need it. And so, as much as possible, we just need to keep that mentality of sharing that information and being transparent in how that information is being used. Again, being explicit about some of our goals here, that we really do want to look after those who have the highest chance of poor outcomes, and you should add to that the highest chance who we can actually help with too, because there are people with poor outcomes that are more difficult to reach or difficult to help, and there are those in the groups that are difficult, that have poor outcomes that you can definitely do something to protect them. And obviously you need to think really carefully about how you actually put resources, whether it's treatments or vaccinations or other sort of restrictions on movements and those sorts of things. You got to be careful to understand the implications of all of those things as you go.
So I think it's been very clear that COVID-19 has highlighted what was there before, but it's really highlighted the importance of data, data management, data modeling, predictive modeling. I think the COVID-19 from that perspective has been it's been positive, if you can say that about a disease that kills a lot of people, but that increased emphasis on the data is certainly appreciated. And I think equally the increased emphasis on the data has helped us do a better job of managing COVID-19, as you say. So that's excellent. Here you go. So Kevin, another question for you, as in your role as research director, what do you see potential from the health information exchange in general, both machine learning and otherwise, to do something, can make a contribution to medical research?
One of the things that's hardest in almost every research project I've been involved in any sector is getting hold of good data. And one of the things that an HIE does already is integrate lots of different data sources and do that at a high volume. So you've got this interesting capability that's there that's also valuable in the whole research context. And so an HIE has potentially a really valuable role to play in that they've already solved some of the data integration pieces of it, and therefore it becomes a point where data is potentially already being linked of, this is all about the same patient, even though it's from different systems, and all those pieces that can be quite a laborious part of a research project where you get sent a few data sets and then have to spend your own time doing that. HIEs have solved that from an operational perspective. So if we take that as one of the core capabilities of the HIE and add to it the ability to de-identify that data, then you can create a repository of data that is really valuable to researchers because it's high volume, high quality, and it's already been kind of quality checked by the fact that it's actually been put through the technology. Apart from all of that, the HIE adds another potential role, which I don't think I've seen happen at a large scale, but it's also potentially a point of deployment for the actual algorithms that machine learning create. And so again, because lots of data flows through it, and at that point you have all of the elements that you need to run a model or to develop a model, we can see a future where a lot more algorithms that take all of the different inputs that an HIE collects can then produce output patterns. And, we work on things that are sort of in the realm of, patients like this, what are typical outcomes for people in a similar cohort. The HIE is a perfect place to actually understand, who is that similar cohort, and then potentially include that information when the data then gets shared downstream into a health provider, for example, sending that data on and including with it some algorithmic information that machine learning has come up with. There's potentially a really good application role for the HIE as well.
I think from a clinician perspective, that would be very exciting. Might be a nicer way too, because I think if it makes predictions, I can handle uncertainty in that. Look, there's a 50% chance this person may have a heart attack in the next 5 years. That's information we can probably assimilate and use clinically, and as you say, from a research perspective as well. So, look, that's been very interesting, Kevin. Thank you for joining me today on Chief Among Friends. For more information, don't hesitate to contact me on Twitter at Dr. Chris Hobson, LinkedIn. Visit our website at www.orionhealth.com.